Good morning. Welcome, all of you. Thank you very much for joining us. Welcome to COVID-19, What is Next for Rotary. Uh, we're going to spend the next hour exploring what COVID-19 means to us individually, to our clubs, to our community, and to the world. I am Brad Howard. I'll be your moderator for this session. I'm a Rotarian from the Rotary Club of Oakland Uptown, District 5170. And so I'll be helping to introduce the panelists and handle their question and answers. We have three panelists, as you've known from the program. Each of them will speak about 10 minutes in their field of expertise. And then at the very end, we're going to open it up for questions from you. So as you will note, you're muted, and therefore you'll not be able to ask the questions verbally, but we would like you very much to put them into the chat box. We will be monitoring the chat box throughout. We'll be stacking up those questions, and I'll be asking the panelists on your behalf those questions. So please make sure to take advantage of that. I'll remind you a couple times as we go along. The best way to view this session will be in speaker view. For those of you who are not immediately familiar with what I just said, if you look in the upper right-hand corner of your Zoom box of the panel, you should see the word view. And if you click on that, you should see something that says speaker view, side-by-side speaker view. We will be using PowerPoints during this, and so you'll want to have that so you can see both the PowerPoint and the person who's speaking, as opposed to the PowerPoint and 100 small boxes of all the people who have joined us. So I want to start out, before I get into introducing the panelists, just to acknowledge some of the people that are working in the background. First, I obviously want to start with our Governor-elect, Danielle Lallement. Danielle, thank you very much for putting this together, and for volunteering to be a governor through the process. So Danielle, thank you. But also I want to acknowledge three people that you may not see. You might see their boxes there, but they're integral to the success. Sherry Teresi, thank you, Sherry, for your expertise. Tice Fields and Jonathan Nichols, thank you all for making sure that all these things work and work flawlessly. So now let's get into the panelists. I'm going to spend just a moment giving you a brief introduction of each, but I would counsel you to go to your program book. There's a much more detailed background of each of these people, and their backgrounds warrant you to take a look at it. We have three wonderful people on this panel to share their expertise and their views about the pandemic, where we are, where we're going, and what it means. So in reverse order to those that you will see, I'm going to introduce you to Matt Willis. Dr. Willis is the Marin County Public Health Officer. You may recall just over a year ago that the 6 Bay Area counties and the city of Berkeley were the first in the nation to shut down to protect its population from getting the vaccine. Dr. Willis is one of the people at the table making that decision to avoid us from contracting COVID. Unfortunately, about 2 weeks after doing so, he actually contracted COVID in an effort to, I guess, sample what it was like as a public health official. But welcome, Dr. Willis. Second person you'll hear from is Laura Zatella. She's a registered nurse from UCSF Health, and she is recognized as a national nurse practitioner leader. She's going to talk to us all about the vaccines. And as you know, there's a lot to unpack there as to where they are, what it means, when I can do what, all those questions. But to start out this program with, we're going to hear from Dr. George Rutherford, who is a noted epidemiologist from the University of California at San Francisco. You may actually be familiar with that name, particularly if you listen to KCBS. He's a frequent person in the Ask an Expert area, where he gets a chance to share his overview knowledge about where we are right now and what it means and how all the things come together in the science of trying to manage and eradicate a disease. So let's get going with this. George, please take it away.
Thank you so much. It's a pleasure to be with all of you. And I'm going to talk a little bit today about epidemiology and quite a bit about international aspects of SARS-CoV-2. So just as a kind of starting point, we differentiate between the virus and the infection that the virus causes. And that virus is called severe acute respiratory syndrome coronavirus type 2, or SARS-CoV-2, and the disease, the actual clinical disease, which occurs in about 60% of people who become infected, and that's called COVID or COVID-19. So just so as we flip back and forth between those, just didn't want people getting lost. Um, there have been 29.7 million cases of COVID-19 reported in the United States as of yesterday, including about 60,000 cases on Thursday. We're right at that clip, and as you'll notice, we've stopped this really rapid decline and have entered almost a plateau here, where some places are going up and some are continuing to go down. Unfortunately, we've had almost 540,000 deaths from COVID. This is probably an undercount, and it's tragically, it continues with 1,549 recognized deaths on Thursday. In California, with 12% of the population of the country, we've now had about 12% of all the cases, but not 12% of the deaths, luckily. You can see that things are continuing to decline after this massive winter surge, and they're still continuing to decline. And mortality is also thankfully continuing to decline. And we're averaging right now currently a little less than 200 deaths per day statewide. Much of this is concentrated, by the way, in Southern California. Now, just in case you think everything's going hunky-dory all over the country, it's not. And at least in two places in the upper Midwest and around New York City, cases are starting to go up again. Here in Michigan, you can see that they got down to a nadir here that was kind of almost on the same order of magnitude as during the summer. And it started back up again. Whereas in New Jersey, which is really, this is the big fall peak, it really hasn't gone all the way down, and went about halfway down from the peak and has now started back up again. That's true in New York, Connecticut, Delaware, Rhode Island as well. So, and this is because mostly because of variants. And I'll talk a little bit more about variants, or we can ask questions about it, but it's something to be cognizant of. Variants are a big deal. These are mutations that just naturally occur in viruses. And there are some that we worry about more than others because they seem to be able to not yet, but we're concerned that one day we'll have mutations that can escape the types of immunity that we're inducing with vaccination. Nationally, one of the big ones is the B.1.1.7 variant. I apologize for the nomenclature. I didn't make this up. This is typically known as the UK variant. This is what's spread around London and southeastern England around Christmas. This is what's responsible for the outbreaks in New York and the upper Midwest. And it probably is about 10% of all the isolates in the country right now. In California, we have a couple of other variants, which used to be called California variants. They're now called West Coast variants. Don't ask why. And they account for about 10% nationally, but in California right now, they're more than half. And we'll have to see how this works out. The 117, the UK variant, is clearly more transmissible. And the British at least think it's associated with more severe disease and worse outcomes. The California variants, as far as we know, are slightly more transmissible, but we do not have any evidence yet that they're associated with worse outcomes. And all these strains seem to be, these strains that I've talked about seem to be pretty susceptible to vaccination. In California, you know about the famous tier system, San Mateo. It's actually in the orange. Probably Marin and San Francisco will go to the orange next week. Maybe even Alameda. I hope that's where I live. And these are just some data. Things are going well. You can see the big drop off in the proportion of tests that are positive and the big drop off in hospitalizations. But and then just to say, while Laura's going to talk mostly about vaccination, I thought I'd give you just a big statewide numbers. California has given more than 13 million doses. We're vaccinating at about 350,000 doses a day. Last Tuesday, there were 450,000 doses given in California. So we really can push this pretty hard as long as we have the supply. 23% of Californians have received a single dose, and 11.1% have been fully vaccinated. And here you can see, I didn't put in San Mateo and Marin, but in San Francisco, there is a large chunk of the population vaccinated. And a lot of this is because San Francisco has a lot of healthcare workers that live in it who got vaccinated first, and that's pushed this number up a little bit. Okay, so what can still go wrong? Mask fatigue and breakdown of non-pharmaceutical interventions. Witness the states of Texas and Florida. Maldistribution of vaccine with pockets of underimmunization. One of the things the state is being very aggressive about addressing. These variants that we worry about, which we are looking for, with an eagle eye. And what I was going to talk about just for the rest of the time is ignoring international spread, which is just, I think would be of interest to you. So these are WHO regions. This is North and South America in whatever color this is, goldenrod or something. And you can see that this is, these are actually going up slightly. And for the first time in ever, Brazil has had more cases than the United States. We're clearly the leaders here. The next country in the Americas is Mexico or Colombia, which are both pretty far down the list. The big problem has been in Europe, and you can see that there's been this surge in Europe, and that's something to be really cognizant of. Italy and France have the highest number of cases. India and Southeast Asia, and the purple, has been coming down gradually, and the other places aren't heavily affected yet. This just gives you an idea of where things are going on, really all over South America, the US, and then really almost all of Europe, with a few other pockets here and there. And here in Europe, where they don't have enough vaccine, by the way, this is what their problem is, and they have this variant that spread from the UK. This is all variant driven in the face of too little vaccine. And by the way, Michigan probably has had too little vaccine distributed, which may be one of the reasons they're in trouble. But here you can see the Czech Republic, Hungary, parts of Italy, Slovakia, even here in Slovenia, Croatia, northern France, and Sweden and the Baltics all are really getting hammered right now. A lot of countries have gone back to lockdown, particularly in the Lombardy region of Italy. And this is full-on epidemic control right now, again, in Europe. Now, in response to this need for vaccine worldwide, because if we don't control infection worldwide, meaning the United States, will keep getting reintroductions of more and more complex viruses. The UN has put together this initiative called kovacs, which is it's sponsored by the World Health Organization, Gavi, the World Immunizations and Vaccines Initiative, and the Coalition for Epidemic Preparedness Interventions, with UNICEF as a kind of a fourth partner. Its goal is to supply 20% of vaccines to countries' populations, which is 2 billion doses. And the way they do this is to try and accelerate development and manufactures of COVID-19 vaccines, and while trying to guarantee fair and equitable access. Countries can buy into this, or they can either self-fund. There's donor money that comes into this. There's a lot of advanced market commitments that COVAX has undertaken. Just gives you kind of a idea of first round allocations. 237 million doses of the AstraZeneca vaccine, which by the way is fine, to 124 countries. These are the 5 biggest countries. You can see they're spread all over the world. And then Pfizer also has donated a half, I don't remember exactly how many hundreds of thousands of doses, but Colombia, Peru, Philippines, South Africa, South Korea, and Ukraine each received the same number of doses. President Biden has pledged to donate $4 billion to the global kovacs campaign, and here it's being unloaded in Khartoum and Phnom Penh. And then finally, yesterday, the U.S. announced that it was giving 4 million doses that we probably weren't going to use to Mexico and to Canada, with 2.5 million doses to Mexico and 1.5 million doses to Canada. And yes, this is the AstraZeneca vaccine. So I'm stopping there, and I'm happy to answer questions when the time comes. Thank you.
Great. Thank you very much for giving us a global view, and most certainly trying to give us the statistics, because I think we get flooded with a lot of statistics and aren't sure where their sources and where they're from and which ones we should track and which ones are estimates. But you've helped us to at least get a good footing to get into the next phase, which will be to have Laura Zatella join us and talk about all things vaccine. So welcome, Laura.
Thanks for having me. I'm delighted to be here to talk to you today about the basics of vaccines and vaccine safety. Next slide. So this is a picture of what the actual virus looks like. And I'm showing you this because the little red parts on there are what we call the spike protein. And I know we've all heard a lot about the spike protein, and that's going to be really important in terms of understanding how vaccines work with our immune system. So this is a picture of the actual virus, and then we'll move on to the next slide. So I often hear the question, which vaccine should I get? Which one do you think is the best? The answer is the vaccine you can get. So we're going to talk about the effectiveness of all the vaccines and the safety. Next slide. I've listed here 4 of the COVID vaccines. The first 3, the Pfizer, Moderna, Johnson & Johnson, are all approved in the United States right now. The AstraZeneca, we hear a lot about in the news. It's not approved in the United States, but I thought I would put it up there. So you can see that these vaccines have been tested in tens of thousands of patients in clinical trials, and now millions of people have been vaccinated with it since. The Pfizer vaccine and the Moderna vaccine are both mRNA vaccines, and they both require 2 doses. The Pfizer vaccine 21 days apart, and the Moderna 28 days apart. The Johnson & Johnson vaccine only requires 1 dose, and it's an adenovirus vector vaccine. And we're going to talk about what mRNA is and what the adenovirus vector vaccines are in a minute. So I've listed here some of the statistics that you've seen about the effectiveness to prevent COVID vaccine, and you can see it varies between viruses, but they're all highly effective, and they all provide some protection against the common variants. And we're continuing to collect data on how well that works. And in addition, some of the companies are working on developing vaccines specifically against some of the variants that we're seeing. But I think the most important take-home point from this slide is outlined in the red box, and that's protection from COVID-19 related death and hospitalization. And all of these vaccines prevent it 100%. And that is our number 1 priority, is to prevent death from a preventable illness. Next slide. All right, so given that these vaccines are so effective, it stands to reason that everybody would want the vaccine. But there's still some hesitancy about obtaining the vaccine. And the number 2 reasons why people say that they're worried about getting a vaccine is the speed with which it was approved, and the potential for side effects. So I want to address those two things in this presentation. So first of all, I think that calling the vaccine effort Operation Warp Speed was an unfortunate branding of it, because actually what happened at such warp speed was that we put all of the resources and the funding into accomplishing a really amazing scientific achievement, which is the development of a vaccine so quickly. This mRNA technology has actually been around for 30 years. And there's been a lot of effort in trying to use this technology to fight cancer and other diseases, including infections. So some of the challenges with mRNA, and what is mRNA? Let's start with that. So mRNA is basically, mRNA and DNA are both genetic instructions for telling a cell how to make a protein. And initially, when they started looking at mRNA, there were some challenges because when it entered the body would immediately degrade it. So we've learned since then you can take the mRNA, these instructions to make a protein, and wrap it up in a fat molecule. And you can see from the picture on the left, in the green, you have the mRNA surrounded by a fat molecule that can enter the cell and actually make your own cell make these little spike proteins. And then the spike proteins are expressed on the outside of the cell, and your immune system is tricked into thinking that that is the spike protein from the coronavirus and can develop antibodies to it. Next slide. The adenovirus vaccines work very similarly, except for they use DNA as the instructions for making the protein, and the DNA is wrapped in an adenovirus shell, and that can enter the cell, and again, the cell is instructed to make the protein, and the proteins you can see in the picture on the right are expressed on the cell, and your immune system can develop antibodies. And those antibodies remain in your body so that if you ever are exposed to the coronavirus, your body can respond very quickly. Next slide. So who should get vaccinated? Nearly everyone. Already over 100 million doses have been administered in the US, and it's safe for people with various health conditions or even allergies. These vaccines do not contain eggs, preservatives, latex, or gelatin. What they do contain is polyethylene glycol, which is a very common laxative. You may have heard of Miralax. Of course, it's in minute quantities, so it doesn't cause diarrhea. And the J&J vaccine contains polysorbate. So if you happen to be a person, and this is extremely rare, that has an allergy to polyethylene glycol or polysorbate, then you can receive the other vaccine. All right, common side effects. So the most common side effects are local reactions in the arm where you get the injection. You can have pain, redness, or swelling that usually lasts a couple of days and can be treated with Tylenol or ice packs. In addition, you can have some side effects throughout the rest of your body, like tiredness, headache, muscle pain, chills, fever, or nausea. And these are not signs of infection. So none of these vaccines contain live virus, and you cannot get infected from the vaccines. But what this is your body's natural immune reaction. It usually just lasts a day or two, and it's more common after the second dose, and it's more common in younger people than older people. Next slide. Once you're fully vaccinated, and we consider you to be fully vaccinated after you have had the complete 2 doses of the Moderna or Pfizer or the 1 Johnson & Johnson, 2 weeks after you complete the vaccines, you're considered fully vaccinated. And at that time, the CDC says that you can now gather indoors with fully vaccinated people without wearing a mask. You can gather indoors with unvaccinated people from one other household, unless any of those people have an increased risk of severe illness. And in addition, if you have been exposed to someone who had COVID-19, the chances of you getting it are very slim. And so you don't need to quarantine, unless, of course, you live in a group setting where you should quarantine if you are exposed to somebody. Next slide. All right, so what can Rotarians do and what can we all do? Even with vaccination, it's still important to adhere to the public safety measures, wearing a mask, staying 6 feet apart, and avoiding crowds. But we all can provide information and encouragement about vaccination and the public health safety measures to our family, to our friends, acquaintances, and to the community. And all of the Rotarians are very respected in the community and do such good work and continue to serve as role models in this regard. There's also been a lot of questions about how to find out if you're eligible for the vaccine and when you can get the vaccine and where. And California has developed a website to sort of bring all of that information into one place. And that website is called My Turn. So if you Google California My Turn, you can enter your information and it will let you know if you're eligible for the vaccine and the locations that the vaccine are being offered near you. In addition to this website, your county health department website also can be a good resource and has a lot of helpful information. Next slide. Thank you.
Wonderful. Thank you very much. I was going to remind people to put in some questions in the chat box, but I have to say that during your comments, Laura, they made up for it. There's quite a few questions that'll be coming to you about that, and even a few more for George. So thank you for sharing that information and wisdom. And now to take us to a broader view of public health, if we could please hear from Dr. Matt Willis. Matt, take it away.
Thank you. Thanks for that excellent information, Laura. I always learn a lot each time I hear my colleagues present. And also want to just start by thanking you all as Rotarians for your ongoing commitment to public health locally, regionally, and globally. I spent part of my career in sub-Saharan Africa working on tuberculosis and HIV. And that Rotary insignia is present everywhere I've worked internationally, doing really good work. And I think today is an opportunity to talk a little bit about how Rotary might be influential as we move to a global perspective with COVID-19. Next, please. So Brad referred to this. This was it's worth acknowledging that this is the 1-year anniversary of the stay-at-home order. It has been certainly the longest year for many of us. My son was in a play at the end of February and was just showing me the program from that. I couldn't believe that it was only 1 year ago that we were actually gathering indoors for school productions. It seems like at least 10 years. Anyway, and just I was looking at this press release that accompanied the stay-at-home order and remarking on a few things that really show how much has changed. One was that the concept of social distancing was just being introduced. I remember gathering with the other health officers there in Santa Clara for the press conference. And we had to really remind ourselves to stand apart, to model what was a new behavior, for us and for our communities. And you'll also notice in this picture that we're not covering our faces. And this was a large indoor gathering, lots of media present, with not a lot of ventilation, windows closed, doors closed. Obviously, we've learned a lot about the role of facial covering since then. And this was 5 days after this event, I started developing symptoms myself. And it's quite possible that this was actually the event in which I was infected. This is also indicated that we would be sheltering at home for 3 weeks. Sarah Cody, health officer for Santa Clara County, said, temporarily changing our routine is absolutely necessary. Well, it's obviously been much more than just a change in our routine, and it's been ongoing. It's been over a year now, and we're still profoundly different in our behaviors. Next slide, please. So will we be on Zoom forever? I think this was one of the questions that I was asked to help address for Rotary as a group that is a social group. It's in a normal business is characterized by regular meetings in person, which are obviously valued by all of us. So what is that going to look like for us over the next few weeks or months? The short answer is that I can't say, and no one can probably say. If anyone claims to know the answer to that question, they're probably not looking at all the evidence, because as George alluded to, there are many unknowns here, especially with regards to the variants, with regards to the influence of people's personal behavior when we start seeing cases increasing globally, cases increasing even within the United States. It's difficult to offer a very clear prediction, but I'll offer some of the principles that we can look to and can help Rotarians understand what the future might look like. First, it's, that will be dependent on policy and practice, right? The indoor gathering guidance will be partly dependent on policy, and then obviously the success will be dependent on how well people actually institute those policies in their own practice. California Department of Public Health sets the recommendations for the state. Those come generally from the CDC nationally. Those guidelines are currently being actively revised at the California Department of Public Health. And then importantly, local health departments can be more, but not less restrictive than the state. So you're really looking at state guidance as well as local guidance. In most cases, it's fully aligned. But in some cases, there's local reasons why we might choose to be more restrictive than the state would allow. So you need to look at both places for the policies. Next, please. So this is the orange tier, as George referenced. If the three counties here are San Francisco, Marin, and San Mateo primarily, all those counties will be in the orange tier, among the first in the state to be moving into that status. San Mateo, I think, was the first in the Bay Area this week. We're moving on Tuesday, the rest, San Francisco and Marin, moving into orange. And just to briefly review what that means for us, it's essentially opening a lot more capacity indoors compared to what was already open in the red tier. 100% indoor grocery and retail, 50% indoor dining, 50% movie theaters and houses of worship. Gyms and fitness studios are open now 25% indoors. We've now opened indoor pools for the first time. Breweries and wineries that don't serve food now can be actually open indoors. We're opening bars that don't serve food, but that's only outdoors. Offices, so non-essential offices can now be open for people to come into work, although we're still recommending that people work remotely. And then higher education is able to open it, lecture halls at 50% capacity. The next tier after orange is yellow, would be further reopenings, higher percent capacity indoors. And the earliest that we would move would be for San Mateo would be April 7th. And then for San Francisco and Marin would be April 14th. And indeed, it does look like we're heading in that direction in terms of our case numbers. Next slide, please. So this is a screenshot of the website where anyone should go to look to see where we are at any given time with regards to the guidance. This is the industry guidance to reduce risk, and it breaks out all the different industries, including faith-based gatherings, offices, restaurants, etc. And this is where Rotarians would look to see what the guidance would be for indoor gatherings related to your meetings. Next, please. And I'll just briefly summarize what that guidance now contains. So this is, I've circled there the orange tier, which we are all in or will be shortly. And it says that indoor gatherings are strongly discouraged, is the current recommendation. This is very recent guidance from March 11th. So indoor gatherings are officially strongly discouraged, are allowed with modifications, and the maximum is 3 households. So this is that social bubble concept where people are allowed to gather indoors with people within their social bubble, those that they've chosen to travel with over this pandemic experience. And then, as Laura said, also being allowed to gather indoors. Vaccinated groups can gather indoors, or one group that's been vaccinated, another household that has not, with certain limitations. Next slide, please. Importantly, if you look at the bottom, the orange column on the bottom, it says starting effective April 1st, And this is a harbinger, I think, of what we will expect is increasing permissions and loosening restrictions. Starting effective April 1st, for outdoor gatherings, you can have a maximum capacity of 33%. So if the capacity of any outdoor setting would be 1,000, you could have 330 people gathered together outdoors across households for outdoor events, for concerts, etc. And that's really the first time the state has offered us that kind of permission for that kind of activity, gathering socially across groups. And as a sign, I think, of the fact that as we move down through the tiers and we recognize that these things can be done safely, especially outdoors, there will be more and more guidance to allow us to do more. On the left there, it says that indoor gathering guidance is forthcoming. So we should look for the next week or 2 weeks from now to have more guidance regarding indoor gatherings that would help you as Rotarians with your future schedules. Next, please. So these are the key factors determining safety. Is ventilation. This is critical. Really aiming for 5 full air changes per hour. That's the ACH. If you think about it, it's just the volume of air in a given space. That if that exchanges, once every 12 minutes or so, that's enough air exchange to protect people indoors, especially if they're covering their faces and maintaining physical distancing. The good news is that it doesn't take a lot of technology to achieve that. It's achievable with 2 windows open, 6 inches, and a door open, in a standard classroom size room. So a 30 by 30 square foot room, you can achieve that 5 full air exchanges per hour without extra technology. Portable air filters are a way to actually increase that, but are not necessary if you have access to the outdoors through windows. Obviously, outdoor gatherings are far safer, along with facial covering, distancing, and greeting practices, making sure that people aren't, which is so obviously common to us when we greet, shaking hands, etc. That's something not to do, at least through the summer and fall. And then knowing your personal risk factors, people who are at higher risk for bad outcomes if they were to have been infected, should also perhaps avoid indoor gatherings where there might be a hybrid model where some is offered virtually and some occurs indoors together. And then vaccination status, as Laura mentioned, is another critical factor that will determine the policies moving forward. As more and more of us get vaccinated, I think we can expect to have policies that tie more explicitly to people's vaccine status that might allow us to gather together. Next slide, please. The good news is, insofar as vaccines are going to be a determinant of our safety together, is that those on this call or the groups represented on this call are among the most highly vaccinated communities in the state of California. This shows doses per 100,000 residents. Marin, San Mateo, and San Francisco are three counties in the top 6 most vaccinated counties in the state of California. So due to a lot of aggressive work and access to vaccines, we're fortunate to be part of communities that have been relatively well vaccinated thus far, and that will continue. Next, please. And this is just another piece of good news that I like to look to when we're thinking about what the future might look like. This is that every day I look at the number of people who have been vaccinated and I look at the number of people who've been infected. And that ratio keeps getting better and better. Fewer and fewer cases, more and more people getting vaccinated. And that inverse relationship between those two things is really going to be the recipe for the solution as we move out of this pandemic. And right now, every day in Marin, at least, for every new case, more than 100 people are getting vaccinated. And we're seeing fewer cases as we move down through the tiers, and we're getting more access to vaccines. We're vaccinating about 2,500 per day now on average in Marin, and that's similar rates across the Bay Area. Next, please. So looking ahead, there's a promising pace of vaccinations. We're being told that we're going to be getting more and more supplies over the next few weeks, nearing that point of 50% of adults in the Bay Area region before the end of March. Right now in Marin, and it sounds like also in San Francisco, about 44% of our adults have already been vaccinated with at least 1 dose. We're anticipating by the end of March, that would be 50%. We are anticipating significant changes in the guidance and allowances for indoor gatherings before summer for you all to pay attention to. And then the wild cards that George mentioned are the variants. Obviously, the B.1.1.7 variant that's becoming more prevalent in other parts of the United States. Right now, it's about 3% of the strains that they've tested here in California, but that's a huge concern. And if we can stay, this race between the vaccine and the variants, if we can stay ahead of that, it will stand us well for the summer and fall. And then the other wild card is behavior, making sure that we don't let down our guard and see our progress as a sign that that the coast is clear. It's not. We need to continue to stay the course. Next, please. And then just to reinforce the global perspective that George offered, global vaccination rates now are about 3%. Our vaccination for all population, not just the adults. So if you look at everybody in Marin, it's about 1 in 3. So we're well more than 10%, or 10 times the vaccination rates in the United States compared to the rest of the globe. And we really are not going to be out of this pandemic until we have global coverage. And the more countries that don't have access to vaccine, the higher the likelihood for new mutations to arise that might evade the protection of the vaccines that we do have. So it's important to keep that global perspective as well. Next slide, please. So in summary, our COVID-19 transmission continues to decline. Reopening brings new risk and new responsibility. Vaccination remains our highest priority from a public health standpoint. There are many unknowns regarding the pandemic path, especially with regards to the variants. So the next few weeks are going to be pivotal for us. We need to stay the course, and eventually the focus will shift to global coverage. Next slide. Thank you. And we can do it. That's my 10-year-old at the Rosie the Riveter Museum in Richmond.
That's cool. Thank you for ending with us, giving us all a smile at the very end through all the process and all the information. So thank you. So now we get into the fun part, the question and answer period. And I think what I'm going to do is start actually with you, Matt, because that's the most recent one. And let me just start with a question that I know is on everybody's mind on this call. Is I know you said you really can't predict what's going to happen next, but so let's push it back for a non-determined time limit. What will the new normal be like? I mean, what should we expect when we finally got our hands around COVID-19 and it's under control and we feel all right? Did we just completely change the way we're going to be interacting with people? I mean, what do you see? Because Rotarians are highly social. We gather weekly, share meals, hug, shake hands, laugh, talk loud, all the things you probably should never do again. What is it going to look like?
I'm definitely not going to be the person that says we should never do those things again, because we do need those things. I mean, that's part of what people need from one another, right? And what we've missed so much over the past year. I think it's really been important to acknowledge that while we've really organized our strategy around preventing transmission for the sake of survival, it has been at the cost of other things that are intrinsic to health and well-being, especially personal interaction. There's been an epidemic of loneliness as well, and isolation. And we do recognize that influenza, for example, this year has been absolutely off the charts in terms of as a record low. We've had one pediatric influenza death in the United States this year. And it's probably because of those things that we've done to prevent transmission with COVID-19. So the societal question is, where do we value being able to interact in ways that we know, that we acknowledge do lead to transmission of viruses? Obviously, I don't think any of us would sort of draw that calculus to say, therefore, we should just always be facially covering forever, and we should never be gathering again. But we recognize that does bring the risk of transmission. And I think we've learned a few things about how to do that more safely. One is, frequent hand washing. That's not touching our face, maybe not hugging as much. I think it's going to be right now. I think we're focusing so much on just getting through this with the death rates that are still climbing. But I think that's going to be the next conversation. We're looking for guidance from the CDC, from experts like George Rutherford, to help us know what have we learned from COVID-19 that we can apply to our general health and well-being with regards to communicable disease. I will say that one piece of the new normal for sure is going to need to be better public health infrastructure. I think we've learned that we were flat-footed here. I mean, in terms of just the size and resources that had been dedicated to public health. We've been sprinting as fast as we can right from the start. In this, and we're still building. Our tools are still just trying to catch up to the burden that we're experiencing now 1 year out. So I think that's a mistake we will never make again. And the new normal will be stronger, more robust data systems for surveillance for diseases, larger teams dedicated to public health preparedness and response at the local, state, and federal level. And that's something that I think I'm relieved to know that seems to be one of the conclusions coming out of this so far.
Okay, well, thank you. We'll apparently be doing fist bumps for a while, with gloves. All right, let me move now, Laura. Let me start asking you. There's a whole lot of questions with regards to the vaccines, and some of them are pretty simple, and that is, well, one that came in from Laura McLaren. Can women who are pregnant be safely vaccinated?
Yeah, at this point, we consider it to be safe for pregnant women. There are also ongoing clinical trials where they're specifically enrolling pregnant women to study this more, but yes, it's considered to be safe.
Got it. And how long, what's current thinking?
And the caveat on that is that you have to think about the risk-benefit ratio, because getting COVID vaccine while you're pregnant is very high risk. So that's why we feel like vaccination is the right thing to do.
Getting COVID while you're pregnant. You said
What
COVID
did I say?
You said
Getting
COVID
pregnant
vaccine.
while you're COVID?
No, well, you said COVID vaccine. No, so I have a daughter-in-law who's pregnant, who got it at the end of her first trimester. Now, she's an ER nurse at El Camino Hospital in San Mateo County, right in the belly of the beast, and so that was a no-brainer. I've told other women who are sort of in their second trimester to wait till the third trimester, because you want some carry forward of the antibodies to protect the baby as well. It's kind of like we do with pertussis. Yeah.
Mm-hmm.
Got it. And so how long will these vaccines be effective? I mean, is it a short-term fix? Is this an annual booster? I know that we're still learning, but what's the current thinking? And let me kick that to George.
Well, we know that they're effective for 9 months because that's how long they've been in people's arms. So, I mean, you can only know, that's what we know. That's where we are in counting. I think they'll probably be, so I think that in terms of responding to what we're asking them to respond, to respond to, which is this current spike protein, I think they'll be effective for 3 or 4 or 5 years. However, the question is how much is the change? How much will the spike protein change as these new variants keep coming in? And if we have to get vaccinated, it's more about broadening our, what we can respond to rather than, boosting it up. So that may happen, it may not. We'll have to see.
Well, so let me follow that line of questioning with you, George. Recently, I was listening to KCBS and heard you speak that it was not a good idea to mix vaccines if you had gotten the first Moderna. But what would happen if I got vaccinated with J&J, and now the Moderna comes out with something that specifically, 6 months from now can address a variant more quickly because of the technology? Can I jump over to that, or do I have to wait for J&J to come out with something that addresses it?
I think we have to wait and see. Somebody will be asking those questions. I mean, they use completely different technology, as Laura pointed out. What we don't want is for you to get a first dose with Moderna and a second dose with Pfizer, or vice versa. That's a real specific recommendation. And while CDC makes some noise that maybe in extremis that might be okay, in fact, nobody knows whether it works or not. This isn't about your arm falling off or anything like that. This is about whether you'll actually have an immune reaction, you'll develop immunity as a result of it.
And I can just add to the new normal question. I think that it's important to recognize that the new normal may well be also regular vaccines, right, for COVID-19. The way we do annual vaccines for influenza, it's quite possible that as the shift in the genetics of COVID-19 emerge, that every year there might be a vaccine or two that match new strains that are circulating. And fortunately, the technology allows for that. And it might be more familiar cadence of vaccinations that we see with influenza.
So does this fall into the category of, we get our annual flu shot? Is this going to be the annual flu shot gets these kinds of things in it? Or while you're getting your flu shot, let's get another shot that is specific to this? These different changes. Is that what you're talking about?
Yeah, I mean, I think it'd be great if they can be combined from the technology standpoint. That would make a lot of sense. I think that's being worked on, or it would be separate. I think it's going to have to really follow the science and the surveillance of the circulating strains to know whether or not we need to be doing recurrent COVID-19 vaccines. But if we do, pairing them with the influenza vaccine would be an operational efficiency for sure.
Okay. While we're on the vaccines, there's been a number of questions of side effects. We heard about the AstraZeneca being pulled because of blood clots. There's one person in the audience who, a friend of their grandchild, had a heart attack the day after they got the shot, and therefore their grandchild does not want to get vaccinated. What are we seeing in that, and what's reasonable? I mean, what is the medical profession monitoring for these vaccines to see where there's fragility or reactions? Let me put that first to George, and then Laura, if you want to add on that. George?
So there's a system called the Vaccine Adverse Events Reporting System that's run by CDC and FDA that collects all these potential adverse reactions. I can tell you when you're going out to immunize people who are older, there will be deaths that follow immunization that have absolutely nothing to do with immunization. The problem with vaccinating an entire population is that everything that happens after you've been vaccinated will be blamed on the vaccine, as Dr. Willis knows about autism and all these other childhood issues. So this stuff is studied quite closely, and short of anaphylaxis, the kinds of reactions that Laura was talking about, which are, I mean, they're unusual. I don't really see any kind of road through about why you would have a fatal cardiac event after immunization.
Okay. Laura, you mentioned the possible side effects, reactions, if you will, from the first and the second. If you get the second shot and you get through the first day and there's no reactions of any kind, are you clear free? That's it, I'm done? Or have you heard of cases that a week later you get the feelings and the setbacks?
No, that's really unusual. Usually the side effects are within the first day or two. And within the first 24 hours, most of the side effects. With the exception of the soreness at the injection site, and that can happen again a day or two later and last for 4 or 5 days, but that's also unusual. It's usually just a couple days.
Got it. Well, I found a cure to that, by the way. I had a trainer the next day after I got my first shot, and I was so sore everywhere else that I didn't even notice the shoulder at all. Very easy.
Excellent and healthy strategy.
Well, somewhat. So this mRDNA technology sounds like it really is more extraordinarily promising for other things. Recently heard that now that there's some consideration that it might be a possible vaccine for malaria. Is this technology, did this just open a whole new chapter for us in terms of global health? And let me start, if I can, with Matt, and George, I'm sure you might have some perspective on it.
Yeah, absolutely. I mean, the ability to um, encapsulate a piece of mRNA and introduce it into a cell to have the cell machinery make proteins, can be applied to a variety of different infectious diseases. I mean, that's what you're doing is priming, as Laura said, you're priming your own immune system to make antibodies against something that you have not yet been infected with. And that can apply to both viruses, bacteria, other parasites, malaria, because you're just priming your natural immune response. So yes, there's a lot of promise for this, and that it's a great story. I mean, there are teams that have been working on mRNA technology for years in the background, just barely scraping by with funding, never gave up. A lot of people were saying this is never going to work. You're never going to be able to get mRNA stable enough to put it into those lipid capsules to actually have it survive through from the syringe into the body, into the cell. But they stuck with it, and it's just a great side story to this whole experience, because it's now essentially saving the globe from this pandemic. And it's one researcher in particular, a woman in Michigan, who really sort of stuck with this and saw it through. So yeah, it has a lot of promise for other infectious diseases too.
I'd add that I think it has almost equal, if not more, promise in oncology, in trying to trick the body into recognizing abnormal cells in malignancies and targeting those with the immune system. This might be the real forefront of immunotherapy for cancers and maybe for other chronic diseases where cells actually change configuration.
Got it. So then that's your area of expertise too, Laura, right? Is there a lot of excitement in that area?
There is a lot of excitement about this. In oncology, historically we've had three pillars: chemotherapy, radiation, and surgery. And now we have a new landscape of immunotherapy, because just like cells get infected with viruses and then that makes that cell bad because it's infected, cancer cells are your own cells that go bad. So your immune system has incredibly good activity against being able to kill those cells. And that's using your own immune system rather than having to take chemotherapy.
Got it. That sounds wonderful. Few questions with regards to getting back to the vaccine and access to the vaccine. First, how are we reaching the greatest at risk population, the older people that if they have a computer, they don't know how to use it, and if many of them don't have it, how do we reach those that are having a hard time finding out how to get the vaccine? I'll go to Matt.
Yeah, I mean, we spend a lot of time thinking about this. Obviously, with our vaccine rollout, we want to be really careful not to just perpetuate the inequities that have characterized, healthcare across pre-COVID, but certainly during COVID as well, with disproportionate impact among different communities being at risk for infection, and really wanting to make sure that we're mirroring that with our vaccine distribution plan. So we're in many ways favoring those communities that have been highest risk and highest ongoing risk to most effectively reduce case counts. So it's our Latinx communities, our lower income communities of Black and Brown residents, as well as older residents who are at higher risk for bad outcomes if they become infected. So that's been right now we're about 75 to 80% of our age 65 plus in Marin have been vaccinated. And that's taken a lot of doing. There's sort of you put up the website, you have your vaccine site, you're gonna get about 50% of your people just that way because they're tech savvy and they have computers and cars and they can get there. And then it becomes more and more tricky as you move further and further. So having telephonic outreach, so we've actually have banks of people calling people at their homes, working with their healthcare providers to pull people in if they don't have transportation, actually getting cars out there, neighbors, friends, other community-based organizations, faith-based organizations to help bring people in. And then finally, that last layer is people who are truly homebound and having to send crews out to people's homes to get them vaccinated. And that's kind of the tiered approach that we've been using for all hard to reach communities. The mobile option is a key option for equity. because a lot of people don't have the access to both the online registration tools or the transportation to get to our mass vaccination sites.
Got it. Um, how how aggressive should we be in pursuing the vaccine individually? And I say this because by chance, my 30-year-old and 25-year-old got vaccinated because they decided to go down to the Moscone Center on a Sunday afternoon, late in the afternoon, and see if there was some extra vaccines. And sure enough, they both walked in and got it, which surprised the heck out of the parents. But what should we be doing? Should we be going down to some of these vaccination sites, getting on wait lists? Should we be plugging into our health providers and asking them questions? How do we navigate this individually to try and get vaccinated? And let me start with, if I can, with George, and then I'll see if there's any other input. George?
Yeah, so it's we set up these special vaccination sites in low-income neighborhoods specifically for the people who are living there, and we want to get those people in preferentially because that's where all the transmission's occurring. And to have people coming into those sites and getting vaccinated and leaving doesn't particularly help. On the other hand, throwing vaccine away at the end of the day really doesn't help. So I'm not averse to people coming down and, waiting to see if there's something left over at the end of the day. I think that's okay. But it's a young person's sport, clearly. And you don't want the scenes like in Florida, when they had, what was it? It was the first day and everybody was there and in wheelchairs lined up for 18 hours trying to get their first dose. I mean, you just don't want that. So we have an appointment system. It makes it more efficient. It also keeps people from hanging around who might be infectious as well. You don't want people getting infected in the line for the vaccine. And so if you're not tech savvy, I mean, you're on this call, so you obviously are, but if you have problems, get somebody to help you, get signed up, go get your dose. And I'd say it's as simple as that. And I wouldn't, I think that it's pushing it to hang around, although I'm glad that we're not wasting vaccine.
Yeah.
Yeah. And I would add to that I think we're all much more worried about the people who don't want to get the vaccine than we are about people who are anxious to get the vaccine.
Thank you.
Yeah, I would say it depends. Just quickly, it depends on the site. In Marin, for what it's worth, we have usually less than 5 doses at the end of the day, and we have a plan where we bring them to the jail and we vaccinate our inmates. So in Marin in particular, there's not a lot of reason to go to any of our vaccine sites to wait for leftover doses because we have very few now because we align them very precisely with the number of people we have scheduled, and we bring them elsewhere when there's leftovers.
Got it. Thank you. Well, first, we're at 12:20, but there's still quite a queue of questions. And if the panelists, if you could stay with us a few more minutes, we haven't opened a door of international, which is going to be, there's quite a few questions about that. It would be appreciated. And to all the rest of you, I don't think you have anywhere to be till 4 o'clock on this for the district training assembly. So if you want to stay with us, please. So George, you showed a map at the beginning of where the infections were, and notably was low in Africa. And we've heard about it's been much lower in India than we would have otherwise expected for that health environment for contracting COVID. What's the thinking? What's driving that?
Well, India has the 5th largest number of cases in the world, just so you know, but and those were cases in the last 2 weeks, by the way, on that map. I think that the most likely explanation is underdiagnosis. It's just not getting people diagnosed. They're not testing very much, and it's really only severely symptomatic people who are getting diagnosed, which is the tip of the iceberg. That's the most likely reason. Some other things, if you say, well, okay, everybody's getting tested, we got lots of evidence that says it really is low there, which we don't, by the way. But if we were to go down that track, then what might be the reasons? Well, one thing is there's a tremendous youth bulge in Africa. You know, the bulk of the population are teenagers, and so and young adults. So there's they're less likely to get symptomatic. They're less likely to to show up to get tested. So that's sort of part and parcel of that same thing. And then the other thing is that people are outdoors a lot more. I mean, and whether working outdoors, congregating outdoors does cut down, basically eliminates the risk of airborne transmission or aerosol transmission. These sort of fine particles that we worry about hanging in a room. If you're 3 feet away from someone who coughs in your face, just because you're outdoors doesn't make that magically go away as a risk. So, you have kind of you have underdiagnosis, number one. Part and parcel of that, you may have much younger populations. And then the third thing is that people do stay outside a lot more. And to the extent that helps, that's another potential reason for things being lower. I frankly don't think there's lower. I don't know if people know this, but the president of Tanzania died this week of COVID, one of the great COVID denialists. So that country's having a horrible time. And by the way, the equator runs right through the middle of it. So it's, there's nothing magical about being at the equator or latitude or some of the other things that people have said.
Got it. I'd also heard that obesity was a factor, that in a lot of these countries where it's lower, there was a lower obesity. Is that a factor that is still considered?
That's a risk factor for progression, not for acquiring disease. So to the extent that they're only getting sick, if they're getting diagnosed, if they're sick, yeah, okay, maybe, but.
Gotcha. Matt?
Yeah, I just wanted to add that it's important to look at testing rates when we're looking at case rates. Obviously resources, it was an issue for us early on that we didn't have the resources to test and diagnose the cases that existed in our own communities, despite how well resourced we are. And that problem is obviously compounded in the developing world. So I agree. I think in one way to see what George is saying in terms of underdiagnosis is that the testing rates per capita are low.
Gotcha. Okay, thank you. We've got a number of questions that have been focused on Rotary's engagement, possible engagement. Are any of you individually aware of Rotary's role globally with regards to polio, and whether or not that is going to be an opportunity downstream to help in this cause and trying to address the disease? George, you shook your head yes.
Sure. I know I know about polio, Rotary and polio, and it's totally remarkable. Thank you all very much for your efforts. When I first started at CDC, and this is the Centers for Disease Control and not the California Department of Corrections, I just need to point that out. In 1982, the first outbreak I worked on was 2,000 cases of paralytic poliomyelitis in Taiwan. So I've paid attention to polio over the years quite a bit, and Rotary's contribution has been phenomenal. I don't know that there are any plans. The likely mechanism is through kovacs, which is why I showed you that. That's really the international kind of one-stop shop around this. And, I think that would be a kind of a linchpin for doing this. The head of Gavi, the global immunizations program, is a guy named Seth Berkley, who's an American who's out of the CDC system, again, not the Department of Corrections, out of the CDC system. And so he understands Rotary and the Rotary's contributions well.
Got it. I know we've been directing questions to you folks on these things. I'm going to take advantage of the opportunity of being more than aware of the polio effort by Rotary. And I'm answering a couple of other questions. At this point, Rotary is not funding any of the vaccines. That's all being done through government. In fact, we have mobilized mainly in Africa, of which I'm particularly aware, that the governments are saying, no, we're handling this for now. And the for now has become the key operative element for us, such that I suspect, and correct me if I'm wrong, any of you, that the panelists, that at one point Rotary could play a role because it's going to be that diminishing curve. They're going to get the majority of them, and we're going to be trying to get, like we're doing right now with polio, to get complete coverage. And we have those structures in all of the countries, that particularly in Africa right now, sub-Saharan Africa more particularly, but South Asia. And so Rotary, at this point, our role has been through our labs, through our networks that have been there. In Nigeria, they've used the lab. In fact, it was the same lab that they used for Ebola in Lagos to help when Ebola arrived in that country. So our structure has been useful to date. So far, we're not playing a role in the distribution of vaccines or the funding of them. But we have made it clear to Gavi and to the governments that we are willing to step into a role if necessary when appropriate. But to that point, that's where we are with engaging in this process.
That's great.
Let me come back to a question. You made reference of, George, to the AstraZeneca vaccine, to giving it to Canada and Mexico. How big of an issue is that? I mean, it's better to give away the vaccine than holding on to it, but is this something that's going to put a dent in their situations that'll help to protect us
Yeah,
downstream?
I think so. I mean, we have 850 million doses for 330 million people. Do the math. So to giving away 5 million doses, isn't much of a stretch. 4 million, whatever it wasn't much of a stretch. But it depends on how strategically they're deployed. Canada has a lot of. Canada doesn't have as much vaccine as you'd think. They're behind the curve. So I think it helps things along. And Mexico also has access to several vaccines, but really doesn't have, every bit helps. And especially if this is deployed, say, for instance, to Baja California, where, that's where I hope it goes, is right to Tijuana and Mexicali, they're in normal times, there are 325,000 border crossings a day between San Diego and Tijuana. It's the biggest, most cross border in the world. And, unless this stuff's controlled there, it's not going to be controlled here.
Got it. Really interesting question. I want to read it. I am horrified at the thought of all the millions of syringes that are going to be into the landfill as a result of these wonderful immunizations. What are we doing with these syringes? And is there a better way to do it now that there's so many of them?
I'm waiting for Dr. Willis to say they take them over to San Quentin every afternoon when they're done. But
Yeah, I don't know what the plan is actually in terms of the waste of the syringes. I mean, obviously, hospitals, our healthcare system is generating, medical waste every day, and this is adding to that, and the safety procedures and protocols for biohazardous waste are the same and are being applied to this. But in terms of where, whether or not there's been a shift in the destination or the process, I don't know.
in the old days, this was before the mid 1980s, we'd use jet injectors, which are high-powered air things. You put them on an arm and inject in, and that's what was used a lot for smallpox. It turns out that there was an HIV risk from them. So, because you can't clean the blood, doesn't really all come off after everything. So those are gone. So we really are left with individual needles and syringes, unfortunately.
And this is not a vaccine. I mean, these all need to be injected. There's no oral possibility downstream.
I think it's a pretty tall order to expect mRNA, which is pretty fragile, to make it through stomach acid and then be absorbed in the gut, make it through the liver and get to where you want it to go. I just don't see that happening. I mean,
Wow.
you could potentially imagine an inhaled vaccine, but those have been kind of iffy as well. We don't really have great models of those.
Thank you for describing the ride that a vaccine would have to go through if it was taken in an oral capacity.
Physiology 101. Come on, you guys all know this.
And that's why I didn't get a degree there, but thank you. So there's a lot of questions that we're not going to have a chance to get to, but there's one thread that I'm kind of saving here for the very end, and it is around travel. We've been vaccinated. We wear the double masks, but the CDC says don't travel. Even though I can get on an airplane and it seems to be safe because they're telling me the recirculated air. Why is it that I can't travel?
Well, because CDC hasn't said you can yet. This is the new catchword of the day: in an abundance of caution. ... I think it's kind of crazy. I was just talking to somebody I work with who's in Hawaii. She's been fully vaccinated, had 2 negative tests within 24 hours of getting on the airplane, and then had to sit in a hotel for 3 days in quarantine and then get retested in Hawaii before they'd let her out the door. I mean, that's excessive, I think. And CDC needs to come around and negotiate with other countries what exactly we're going to do about letting people back and forth who are vaccinated. Now, having said that, I wouldn't be, I think there's certain things that we might want to be pretty careful about. I wouldn't be really anxious to have a lot of people come from Brazil, where one of these really problematic variants is, without being clearly, unless we clearly showed that they're uninfected. Going back and forth to Asia, where case counts are quite low, that's a different thing. And I might be up for that, although I don't know if people saw this, but the government of Japan said they weren't going to let anybody in from overseas for the Olympics, or spectators. So that was as of this morning. Too bad, huh? But I was figuring I was going to get my medal finally this year, but this needs to catch up with vaccination. And CDC's just been, they've got a million things to do. And this is one of the things I think the next time they come through and say what's going to happen now that you're vaccinated, that may be one of them. Matt, do you know anything more about that, or Laura?
No, I mean, I know that you have still, international travel, you still need to get tested before you can return. And that, I mean, there's a lot. I think some of this gets to, there are the questions about what can people do after they've been vaccinated. There's been questions about whether or not you need to continue to wear your mask. If the CDC, I think, is challenged right now to have a blanket approach for everyone with the same rules applied to everybody, or where you start carving out exceptions. And that's not a trivial question, because as we start saying, well, if you've been vaccinated, you can X, but if you haven't, you can't, it will erode our sort of common cultural understanding of how we're behaving together as a society. And so by having allowances where people can be out in public without masks because they've been vaccinated, but people who need to wear masks, and find a way to determine the difference between those. I think right now the calculus is erring on the side of a conservative approach for everyone, for the sake of getting us through the next 2 months. So I think that's part of why we're not seeing more liberal travel policies emerge, even though from an epidemiologic standpoint, they may be justified given how effective the vaccine is. And I think that's something we're just going to have to, it's another one of the sacrifices I think we're all being asked to make for the next couple of months, is to really continue to limit our travel to only essential travel, recognizing that that's going to be eroding around the edges anyway.
Okay. Well, we could do this for a really long time. You folks have been just so outstanding in sharing your time, your expertise, your information, and helping us to better understand how we're going to climb out from under this COVID rock and what our promise is for the future, and to the fact that each of you played a vital role in our health, in our communities here. On behalf of everyone attending and those who didn't, thank you for what you do to keep us safe and to allow us to get back to a life that will be some kind of normal. So thank you for the time. Matt, Laura, George, thank you so very, very much for being a part of it. To all the rest of you for attending, I just wanted to say, please, there's a couple of things. If you can go to the next slide, there's a resource that many of you can go to answer some of your questions. If you notice down in the lower right-hand corner, there is a shortened web address, that bit.ly, etc. If you go there, there's a lot of resources there that will answer many of your questions. Again, I apologize that we couldn't get to all of them, but with the number of questions that were submitted, we could be here for a full another hour. There is an evaluation that has been posted in the chat box a couple of times. If you could please take your time to share your thoughts, what worked, what you wish we could do better. We want to do better for all of you. And to all the folks that worked behind the scenes to make this happen and bring us this experience, thank you for putting it together. And that goes to not just the folks who are pushing buttons, but those that arranged to get such great speakers for us. And of course, to our governor, Danielle, thank you for conceiving of this, pulling all the necessary strings to make it happen. For all the rest of you, stay healthy and be well. And let's look forward to the end of this so that next time we gather, we can find out the exact medal that George was going to get at those Olympics. Take care. Thank you, everybody.